Thank you very much for the kind invitation. And I'm going to try to show you in a few minutes about these new techniques in dermatology and especially in dermatologic surgery. So this is my conflict of interest with this lecture. And there was like a hole in the field of imaging, very cellular resolution, but with very low penetration, that more or less 200 microns. But indeed, in the opposite side, we had OCT that had a deeper penetration, more or less 2 millimeters, but with no cellular resolution. So we have this area in the middle that we need something else. So now we have helped to develop this device that it's called linear confocal OCT, that has the fusion of OCT and confocal in the same device. So what is this? You have cellular resolution in vertical. For the first time, you can see in vertical view the detail of normal skin or tumoral skin with cellular resolution, and the horizontal view, exactly as confocal microscopy with cellular resolution also. But what it's more is that we have the fusion of this, and we have this block of the three-dimensional way that we can see in the three-dimensional of more or less 400 microns, the epidermis or whatever, the skin in 3D. So it's amazing. So this is one of our first papers in this field. I'm going to tell you in this about melanocytic lesions that it's revolutionary, because it's the first time that we have some device that we really can have with cellular resolution a comparison with confocal microscopy. And as you see here, in this paper, we compared the exactly same area, okay? So we saw with the dermoscopy. This is confocal microscopy. This was exactly the same area. Scan with LCOCT, as you can see here. Look at this hole here. So it's the exactly same with histologic cyst, that it's the same here. The nest of melanocytic cells that we can see also here, and also the nuclear details of the tibia in melanocytic cells. So it's amazing that we can see also the dermoepidermal junction that is disrupted. And the same image is in the horizontal view of this 3D block that correlated with RCM. So this is the RCM and this is COCT. So fantastic. For the first time, we have this new technology. So, for example, this is we did this like sum up to see that every and single pattern that we can see in confocal, we could also recognize it in LCOCT. For example, I'm going to show you an example of this, atypical, very severe atypical nevi. Look at this dermoepidermal junction with all of this action and inflammation around, and it correlates it exactly with the histology. And here is the horizontal view with the dendritic cells, exactly the same with RCM. So if we can compare in more detail here, for example, we have the vertical view of the LCOCT with this atypia, the cellular atypia in this area. Look at the cyst and the atypia here in the middle, and here exactly the same. The same in this view, and all these dendritic cells, as you can compare here, is the exactly same area compared. You can follow here the dendritic cells is the same, okay? So we did this comparison side by side to see exactly what we defined. And look at this, what it's amazing, that in this area, for example, at this depth, we could see even more details with LCOCT than we could see here with RCM. It's amazing, okay? So, and we did the comparison between both techniques. Of course, that RCM, we had a perfect cellular resolution. And what I honestly need to tell is that the Viva block of RCM is perfect, really, to see the whole scenario of a melanocytic lesion. But for the first time, we have the technology that can compare to the 3000. The same can happen with basal cell carcinoma. Here is the RCM, and here are the same cellular details with LCOCT, and here is the histology. Okay, and what is more in dermatologic surgery? This is what we have now, that we can see in real life. We can do these videos all around the area, and with artificial intelligence, we can see if there's presence or not of basal cell carcinoma, for example, in this case. So we're moving around, as you're seeing here, and everything is green. Can you see here? So it's green, there's no tumor presence. And you are going to see in the next one. So green, we don't have. We have here also the comparisons. Everything is perfect, no tumor, everything is green. We're moving around. And all the red areas, we are seeing with artificial intelligence the presence of the tumor. So we can do exactly in vivo margin delimitation, at least at 400 microns. Okay, here you can see one example of positive margins. Again, we're going to move to the center of the lesion, and where you're going to see red, you're going to see red, look here, red. So this is tumor presence, okay? That it's here in the middle. So you are seeing in the exactly same moment that the machine is telling you, here I have tumor, I need to excise more, okay? So this is the new technology that we have now for our patients. And here is the final margin control, in vivo margin control, so we can start our Mohs surgery doing this Mohs delimitation, this delimitation before, and simplify our life. Another case, so here we're seeing tumor here in this margin delimitation here, and again, more and more. Okay, I don't want to keep time, but here is a sum up where we can see tumor. So moving forward, what else is new? Ex vivo confocal microscopy. So in 2001, we had this device that had reflectance and fluorescence in with different lasers. But in 2016, we started to work with this prototype. And we helped Vivascope to develop this new generation of ex vivo confocal. In 2018, we helped them to develop and to put these colors to put it in real life. So this is what we have now. We see the tumor when we excise the tumor exactly like this with regular H&E. So this was the revolution. We know that it helps to see tumor in Mohs surgery for basal cell carcinoma and even squamous cell carcinoma. And I'm going to show you a little bit how does it works. So I'm going to show you a real case. We use this double scalpel to remove the tumor. And you are seeing here, for example, we do in this infiltrating and superficial basal cell carcinoma. So we're removing all the periphery. Why we're doing this? We publish this and that because if we use this double scalpel, it's easier than to flatten the tissue and to see them in the device. We do the debulking, then we excise all the specimen. I'm going to pass it faster here.
Take your time, Dr. Perez, because this is very interesting. Yes? Take your time.
Okay. Thank you. So we are removing the specimen exactly like Mohs surgery, and we're putting here in the exactly same minute in the device. And here, for example, we are seeing the center of the lesion, the debulking, that here we can see basal cell carcinoma. Can we recognize it here? And here we are seeing all the epidermis in one shot, and we are seeing all the peripheral area, all the deep component, and we can see that we have free margins. Okay. So in more detail, basal cell carcinoma of the debulking with this very typical stromal reaction, superficial basal cell. But what's more, we can see a lot of lateral margins in one slide. And this is amazing because sometimes for very huge tumors, like for example, dermatofibrosarcoma protuberans or another kinds of sarcoma, for example, we can put all of them in one slide. We can see all of them at the same time. And here I'm going to show you a practical case that we have 3 years now ago, and it's without recurrence in this very tricky basal cell carcinoma. It was a primary one, and here you can see here in detail all the tumor presence. Okay, everything of this is positive, and this is the macro view that we are having exactly at the same time. And here in more detail, look at the tumor. It was a very, very tricky tumor. Look at this perifollicular basal cell carcinoma. Okay, look, you see the difference? This is normal. You can see here the cytoplasm, and this is tumor. Okay, nucleus are crowded. Okay, another example of the same area, of another area. So all of this is tumor presence. Very, very tiny tumor. And here, this is stage 2. Again, everything was positive here. Positive again, stage 3. Positive again, stage 4. In detail, look at this. This was a tumor. It was also periacrine. Look, this was the acrine ducts, and here the tumor islands. We can see here the detail. Here we can see the lumen inside, and here there's no lumen. Can you recognize them? All the nuclears are crowded. So this is, and you have the palisading here, cleftin. So this is tumor. Here, the cleftin, palisading, stromal reaction around tumoral islands beyond the acrine ducts. Scar, very, very strange area of scar, stage 5, 6, and finally, in this stage 6, look at this. Very, very strange area with all this inflammation. Whenever we have this doubtful area, we decide to remove more, okay? To take a little bit more. And this was the last stage, 7, free margins, okay? And this was the final effects. And if you compare here, this was the first stage, the previous and the postoperatory area, and then with a flap and 1 month reconstruction. And again, doing both techniques, because in Hospital Clínic of Barcelona, we have this challenge and this, it's perfect. We have both technologies. So look at this. This was a basal cell carcinoma, very tiny one. If we see here these areas that Emilio Lalas described like as classifications in this micronodular basal cell carcinoma that we are seeing here with LCOCT, with the stromal reaction, very, very similar to confocal, but when we see in vertical, it's even here are the calcification, and here we are seeing the stromal reaction, and this very micronodular basal cell carcinoma here. It was a very small one, basal cell carcinoma of the forehead, and here with another view, the calcifications that are associated with this microinfiltrating basal cell carcinoma. Here, all the stromal reaction around. And finally, we did a comparison also with the ex vivo confocal microscopy, and if we see here, look at this. Micronodular basal cell carcinoma, the area of the calcification, and the comparison, it was exactly the same tumor, the regular H&E. So this is ex vivo, this is regular H&E, and you can see here, it's almost the same. It's amazing. So this is it. So these are my colleagues of Hospital Clínic of Barcelona, and I really want to invite you. Dr. Rossi is going to be with us. We hope he accepts our invitation to be with us. He is going to give one of the lectures, and we are going to invite you for the 3rd World Congress of Confocal Microscopy that is going to be here in Barcelona.
Thank you so much, Dr. Perez. That was awesome. Fantastic technology. Dr. Rossi, do you have a question for Dr. Perez?
Oh, I know Dr. Perez well, and so many questions. I think for this audience, Dr. Perez, this is probably like very, super interesting, super new technology. Can you just tell us a little bit, how long do you think it takes to operate, on in the regular clinic for someone who's never done OCT or confocal, is it something that we can get started with or?
Yes, yeah, with no doubt. For example, I normally have this, well, the course really, it takes 2 days, really. And in 2 days, you more or less know how to do and the details and how to do the training. And if you want to have and to see more detail, we have some specific rotations here in our hospital, and also Memorial Flow Catering that you can go 1 month, 3 months, 6 months, and to learn. But really, really, from 1 to 3 months, you are an expert doing this. You really don't need more, especially if you are a Mohs surgeon and you really know a little bit of histology. 1 week, you know everything.
And I think for us, it has really helped us decrease the amount of biopsies that we need to do, especially on the face. If we're thinking, you know, it's a suspicious lesion, but we're not sure on dermoscopy, that's when it also really helps to say like, okay, we don't have to do a biopsy.
I have a question for you, Dr. Perez, because obviously this is for skin cancer indication. Does this OCT has other type of indication? Because for private practice dermatologists, which might not have so much skin cancer case, you might like to use it for something else.
Right now, I can tell you, you're going to see them published for a very, very famous mark of solar sunscreen. And we did the test with this device, and it's amazing. So you can see field of cancerization, you can see actinic keratosis, you can see also if you, for example, do some filler or something like this, it's amazing. It's like to have cellular resolution at 400 microns.
Okay,
so you
great.
can control.
Yeah, and people are characterizing more aging with OCT now, like the dermal aging, like they're seeing changes over time as we age, you know, both with UV exposure and just like intrinsic aging.
So that's interesting because there is some, I mean, there are far more indication than pure skin cancer for dermatologic surgery. Okay, fantastic.
Yeah. And just another question, because I'm so interested in this. The algorithm that you're running, is it detecting blood vessels? What is it detecting? Atypia of the nucleus? What do you think?
And there's an algorithm that it's already published that we did and actinic keratosis, but it was with cellular resolution, and it was amazing. The device could recognize field of cancerization and differentiate it from actinic keratosis. It was really amazing.
Wow. Okay.
Wonderful. Okay, great. I think
that can't wait to see you guys.
Okay, thank you so much. If we have time at the end of the webinar, we might have more questions for between you, Dr. Rossi, and Dr. Perez.